All right, I guess it's time to get started. I'm Steve Kossor. I'm a licensed psychologist and a certified school psychologist in Pennsylvania. I was invited here a year or so ago to present to this same conference about Medicaid's early and periodic screening, diagnosis, and treatment program, which I have called for the last several years the greatest treatment funding secret ever concealed. Very few people know about the EPSDT mandate, and almost nobody knows about the content of it. The purpose of my presentation today is to help you understand how within the EPSDT mandate, there is a mandate for the delivery of behavioral health services to children who need them. And I'm going to show you how to access those services or funding for those services and make some recommendations as to how you might be able to do that more efficiently and effectively than you would otherwise. So we'll launch. That is my email address. Please note it and understand that I'm actively encouraging correspondence throughout the year about this. It is a pretty complicated system, and feel free to email me at any time if you have questions about it. Basically, I want to introduce myself in terms of my credentials. This is a letter that was written by Cindy Mann to my state representative, Jim Gerlach. And it says basically, this is not an endorsement, by the way. The CMS does not endorse anything. But they did actually say, quote, "My staff has spoken with Mr. Kossor, and we learned that he has indeed developed an effective approach to serving children and adolescents with developmental disabilities and has made the approach available to Medicaid-enrolled children through EPSDT." So as far as it goes, I've submitted all of my material for vetting, for lack of a better word, with the CMS, with the Department of Public Welfare in Pennsylvania, which is the state Medicaid agency. And everything that I've ever submitted has always come back with the statement, yes, this is appropriate, yes, this is adequate. So you can take this stuff to the bank, that what I'm telling you has been vetted and is the God's honest truth. The next thing to know about EPSDT is that it has been in place as a mandate throughout the United States since 1989 by an act of Congress. It was the Omnibus Budget Reconciliation Act of 1989 that made EPSDT and all of its subsequent programs and supports available throughout the United States in every state, regardless of whether or not there are other programs that might exist to do the same thing, or whether or not other programs did not cover these benefits. For example, many programs throughout the U.S. Offer Medicaid benefits to adults, and they don't come close to offering the kinds of benefits that EPSDT offers. And EPSDT, as of 1989, made those benefits mandatory throughout the U.S. This little blue arrow says that state Medicaid programs must make EPSDT services promptly available for any individual who is under age 21 and who is eligible for Medicaid, whether or not that individual is receiving services under an approved HCBS waiver or any other program. So here is what EPSDT is, and note that it was created in 1967. So it's been in place for almost 50 years. I was honored a couple of months, maybe about a year ago now, at the White House as a champion of change for community-based services for children. And in the part of the program where they offered questions from the audience, I put my hand up and I said, do you guys know that you have had a community-based funding program for children's mental health in the U.S. for 50 years? And the guy from the NIMH was sitting up there nodding, and he knew, but virtually nobody else in the audience knew that funding for children's mental health treatment was an entitlement in 1967 as part of the Medicaid Act. It was expanded in 1989, and the federal government's issued warnings to the states 3 times since 1989, telling them that they have to let potential recipients know that these benefits exist. And as God is my witness, the states have uniformly failed in that mission. They've had to be reminded 3 times of it so far. EPSDT covers a variety of services, and they include prevention and treatment programs. Now, I inverted them. The slide says treatment and prevention, but it's actually prevention that is the EPSDT primary focus. The goal of EPSDT is largely to prevent the onset of conditions or the worsening of conditions that would have kept a person out of military service. Back in 1967, when the EPSDT mandate was created, about 50% of the children showing up at draft boards during the height of the Vietnam War were judged unfit for military service because of the lack of treatment for childhood illnesses. Dental problems, vision problems, hearing problems. All of these things were untreated for large portions of the child population in the U.S., and the Congress said in 1967, nuts to this, we're going to make our population of children healthier than they are now. Well, unfortunately, the situation has actually deteriorated. I was speaking at the Center for School Mental Health Services conference about a month or so ago, and Dennis Embry from the Paxos Institute made a presentation that the Joint Chiefs of Staff commissioned a study last year or in the recent past, and now they're finding that 75% of the children appearing at induction for military service are having severe complications, problems of childhood conditions. In other words, it's now even worse than it was in 1967. So the EPSDT mandate is as potent and necessary now as it was 50 years ago. Its terms have been incorporated into the Affordable Care Act. It's part of the Rehabilitation Act. In other words, every imaginable way of supporting children since 1967 has incorporated these points, and I want to focus your attention on the last one, other services, including mental health care. This is 42 U.S. Code of Federal Regulations 1396 DR5. In the Social Security Act, it appears as Section 1905 R5. Because it's part of the Social Security Act, it is in fact a civil right for children enrolled in Medicaid to receive funding for treatment, and this is a little known corollary of that. This is a quote, treatment that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished. So the question immediately comes to mind, what determines or who determines the purpose for which a treatment is furnished? And the answer to that can only be the licensed practitioner who observed the child, made inquiries, and rendered a prescription. It's not the managed care reviewer that reviews the psychologist or psychiatrist's report. It's the prescriber who determines the purpose for which a treatment is furnished. And every court that has heard arguments like that has found in exactly that way since 1967. So it's not possible to implement managed care with EPSDT funds like you can manipulate or implement managed care in other contexts. In managed care, the managed care entity has a godlike authority over what shall and shall not be given. In EPSDT, the federal government, the Congress, has given godlike authority to the prescribers of treatment to determine what is medically necessary. Now, they are bound to, because of waivers that were subsequently issued, they're bound to submit their work to a managed care company for review and approval. The problem is the managed care companies sometimes overstep their bounds, and sometimes colossally so, and sometimes with the tacit or overt support of the state Medicaid agency. When that happens, a violation of civil rights is occurring. I filed a complaint to that effect in December of 2012. It was studied by the Office for Civil Rights for a year before they actively initiated an investigation, and that started in January of 2014. So there is currently an active civil rights investigation underway to determine whether or not, or rather the extent to which, Pennsylvania's managed care companies and Department of Public Welfare have engaged in a systematic deprivation of the civil rights of children because of their interference with access to EPSDT funding. A Medicaid recipient in Pennsylvania, as in 36 other states, is any child with a disability who is under the age of 21. In other words, income doesn't count. And that's true in 36 states. If you're a child with autism or ADHD or any variety of other conditions recognized by the Bureau of Disability Determination in the Social Security Administration's Blue Book, if you're listed in there, if your condition is listed in there and you're under 21, you're eligible for Medicaid. You just have to have it diagnosed by a licensed practitioner of the healing arts. In Pennsylvania, that's a psychologist or a psychiatrist. Some states allow a licensed clinical social worker to prescribe treatment, and they can enroll a child in Medicaid and make a prescription for behavioral health rehabilitation services. So it really is, it's an enormous opportunity to get funding for treatment, especially mental health treatment, that is so widely overlooked and ignored, mostly through ignorance. Most people don't know it exists. So you see on the screen now the section from the Social Security Act that makes EPSDT funding a civil right. And it says very clearly that services, and that includes such other necessary health care, diagnostic services, treatment, or other measures described in Section A of this section, to correct or ameliorate defects and physical and mental illnesses and conditions discovered by the screening process. And it says, I highlighted it in bold, whether or not such services are covered under the state plan. Earlier you saw that it's services covered whether or not they're funded by any other agency as well. That includes early intervention, so that you can have EPSDT funded behavioral health treatment delivered simultaneously with early intervention services. If early intervention, for example, is implementing behavioral support, that might be construed as a duplication of services by EPSDT, but when you find out the difference between EPSDT funding and every other funding source, and I'll make that plain to you, you'll realize EPSDT is absolutely the preferred source of funding for behavioral health treatment. Think of it this way. You've heard of waivers. Everybody's heard of waivers. A waiver is like a box of breath mints. There's 50 of them in here. They're free. There's a waiting list, and there's only 50 of them, and when they're gone, they're gone. That's a waiver, okay? EPSDT is like a folio of credit cards with the child's name on them, with an unlimited balance. And I'm not kidding when I say unlimited. I'm going to show you actual text from the Department of Public Welfare that explicitly says that. So I want you to understand, anybody who's ever told you that you have to beg, scrape, borrow, and steal to get funding for mental health treatment in this state is absolutely wrong. It's actually one of the easiest things to get once you know how to get it, and that's why I'm here. Also within the Code of Federal Regulations and the Social Security Act, it talks specifically about the services that are provided through EPSDT. And they include diagnostic services, and you see that those are recommended by a licensed practitioner. and preventive services and rehabilitative services. Now look at the middle one, preventive services. It says means services provided by a physician. That's what it said in 1967. The Affordable Care Act amended that statement, and now preventive services can be accessed if they are also recommended by a licensed practitioner. What this means is that my staff, who are not licensed, who have master's degrees and even bachelor's degrees, can go into the home or the school of a child, work with the child right where the problem's happening, help the parent understand how to deal with the child better, help the siblings deal with their sibling better, help the peers relate better to the identified client, help the client stop being entertainment for some of the more sociopathically inclined peers in the classroom. My staff can act literally like a force field in a hostile environment, repelling the more pestilential influences that are trying to get in and exploit the child. It's a perfect way of delivering treatment. I spent about 20 years as a psychologist having people come to my office and listening to kids lie to me about what's happening in their life while their parents wring their hands in the waiting room and hope for the best. I took checks from those people. A lot of my colleagues still do. I figured out how to actually help kids, and that's why I'm trying to make it available to my colleagues who practice psychology in Pennsylvania, especially. So make a long story short, my staff go into the home or the school of the child. They stay with the child 15, 20, 30, or more hours a week, every week, month after month, year after year, until they're no longer needed in the child's life, and the child is autonomous, is able to function more adaptively than they ever could have otherwise, and then goes on and leads a productive life, gets a job, relates to the community in a wholesome and appropriate way, perhaps starts a family. In other words, everything goes onward and upward because they got the help that they need at this level. And we're not talking about a decade of treatment, although children are eligible for this treatment funding from birth to 21, inclusive. The day they turn 21, they're no longer eligible for EPSDT funding. But from birth to 21, they are if they're disabled. So my staff works with kids closely like this, and 90% of the kids we work with are finished in 3 years or less. So we do have some kids who we've worked with for more than a decade, but they are profoundly cognitively impaired. Their learning curve is glacially slow. We're doing the best we can to support them. There are frequent periods of regression. They've got catastrophic other events in their lives, and they need the help, and they can get it. Now, there are people who are running around saying that the BHRS system, actually they started calling it wraparound in Pennsylvania 20 years ago, and that was a mistake. It's not wraparound, and we'll go into that shortly. The technical name for what I provide is Behavioral Health Rehabilitation Services, BHRS. They are part of the rehabilitation services you see at the bottom of the screen. And these services only need to be recommended by a licensed practitioner, so my staff can go into the home, go into the school of a child, work with them one-on-one, providing behavioral support, redirection, counseling, and all of the other evidence-based practices that Dennis Embry and others have identified through the various places that recognize evidence-based practices. We implement applied behavior analysis. That is the only evidence-based practice identified for the treatment of children with autism, isn't it? And we do it. And it's funded 100% by Medicaid through the EPSDT mandate. One of the most important things to understand about the EPSDT mandate is that it is linked inexorably to the state's definition of medically necessary treatment. And that definition differs from state to state. This is Pennsylvania's definition of medically necessary treatment. And I'll read it for you because it's a whopper. A service, item, procedure, or level of care that is necessary for the proper treatment or management of an illness, injury, or disability is one that, and they have three different options, any one of which satisfies the medical necessity of that treatment. The first is that it will, or is reasonably expected to, prevent the onset of an illness, condition, injury, or disability. Now you'll notice they put prevention in the primary spot, just like the EPSDT mandate requires it to be. Or it will, or is reasonably expected to, reduce or ameliorate. Remember that word, ameliorate? It's taken directly from the EPSDT mandate, and it means lessen or diminish. Ameliorate the physical, mental, or developmental effects of an illness, condition, injury, or disability. Or it will assist the recipient to achieve or maintain maximum functional capacity in performing daily activities, taking into account both the functional capacity of the recipient and those functional capacities that are appropriate for recipients of the same age. Now that was published in April of 2007 in the Pennsylvania Bulletin. This is the law in Pennsylvania. So how in God's name can any insurance company in this state claim that when I prescribe a service to prevent the onset of a condition and to ameliorate the current effects of the condition and to assist the child in maintaining functioning, how in God's name can they say, that's not medically necessary? That's a rhetorical question. Obviously, they can't say that. So they come up with other creative ways to deny what are actually a civil right entitlement to children with disabilities. This is a memo sent from the Department of Public Welfare to the Department of Education. And it was sent because the Department of Education appealed to the Department of Public Welfare because parents were refusing to sign the paper allowing the kids to tap Medicaid in the schools. And the parents were afraid that if they allowed that to happen, that it might somehow impede the ability to use Medicaid funds in the home. So the Department of Public Welfare issued this statement to the Department of Education saying that, and I'll quote, "The health-related services a student receives through the School-Based Access program are separate and apart from the medical assistance or Medicaid services a child receives outside of the school setting." And they go on to say, additionally, there is no cap or limit on the total amount of money that may be paid by the MA program for School-Based Access program services or MA services that the MA child may receive. They're quoting federal law. They're not making anything new, but they're just making it obvious that the schools can tap Medicaid to their heart's content without interfering with the tap coming out of the other end going to the parents in their homes. Think of Medicaid as a keg, and it's got two taps. There's a tap coming out the back of it that has a full bore, and it's running full tilt. Over $140 million coming out of Medicaid into Pennsylvania schools last year alone. Actually, it's more than that. Every other state in the nation taps Medicaid to a comparable degree. If you add it up over the last decade, that's $50 billion of Medicaid money flowing into schools. Good for them. They need all the help they can get. But there's another tap on the Medicaid keg, and that one goes out to parents. And the amount of money flowing into the schools cannot be diminished by the money coming out through the top tap, they're both equally valent. This is why schools can tap Medicaid to their heart's content. They have no managed care oversight whatsoever. The managed care companies only control the output of the top tap. And in some ways they're like a pit bull with, terrifically frightening, bare, glaring teeth. But then you realize there's an 18-inch chain around their neck constrained by EPSDT, so they can really make an awful lot of noise, but unless they're willing to violate the kids' civil rights, and unless the state's willing to back them up in that, they really can't restrict the flow of necessary treatment to children made by prescribers who are licensed. Now, that's not to say that a prescriber can prescribe kind of discredited or experimental treatment like hyperbaric oxygen therapy. You've heard of that, right? Believe it or not, the 6th Federal Circuit Court in Georgia mandated that funding for hyperbaric oxygen therapy must be provided to a Medicaid recipient under the EPSDT mandate. There is, in fact, no barrier for experimental services or treatments within the EPSDT mandate. A lot of people think there are. The federal court doesn't agree with that opinion. You're getting a sense of how unbelievably wonderful this could be if only people were courageous enough to prescribe it and then defend their prescriptions. My purpose in making this and other presentations is to encourage licensed practitioners to have that courage, to take the ball with me, use the civil rights option to let the federal government know if states are not doing what they're supposed to do. In fact, we as licensed practitioners are obligated under federal law to make that complaint if we become aware that those services are being impeded inappropriately. The problem you have is that in Pennsylvania and everywhere else in the United States that I can tell, you have a school system that operates in a parallel universe. They have their own courts, they've got their own judges, laws, rules. It literally is a parallel universe. If you can convince that universe that they can be helped if you implement treatment with a tack hammer, not a toothpick, certainly not a sledgehammer, you have to have an appropriate level of care delivered to a child to have a reasonable probability that it's going to help. So if an insurance company is allowed to say, well, you prescribed 30, but he only needs 10, you're defeating the whole purpose of the EPSDT mandate, and that constitutes an obstruction of civil rights to the child who needs the treatment. Now, what do you do about a school? Schools are the best thing that ever happened to managed care in the EPSDT world, because as soon as the school, in its infinite wisdom, determines that the child doesn't need what the psychiatrist prescribed, you're dead in the water, because EPSDT funding cannot override the child's IEP or school program. It has to collaborate with it. So if you can convince the school, look, guys, what are you saying? You're saying no to what the kid actually needs. Why? And you have to ask them off camera, because they won't tell you on camera why. The truth is they're afraid that they're going to be left holding the bag to pay for it. And this is something else you've got to understand about EPSDT and Medicaid. And far too few schools understand this. It's very important that you understand that in schools, Medicaid is the payer of first resort, not the school system. Medicaid, if it's a covered service under EPSDT. Covered services under EPSDT are all of the services listed here. Treatment and prevention services, physical, speech, and related therapies, hearing services, eye exams and eyeglasses, durable medical equipment, home residential and inpatient care, dental care, and other services, including mental health care. All of these are covered services under EPSDT. So technically, a school district that does not want to pay for eye exams can simply say, well, those are covered services under EPSDT, and we insist that the Medicaid system pays for them, not us. And in fact, most school districts do that. The thing that they're missing is the one at the bottom of the page that says mental health services. So let me explain this one slide here. The School-Based Access program, as we knew it, was administered by Leader Services until they lost the contract a short time ago, and they were replaced by another outfit. The new outfit is much, much less forthcoming about the financial aspects of School-Based Access program funding. But the Leader Services stuff is still up on the internet, and you can still consult it, and you'll see a variety of things in there that are still true regarding the School-Based Access program. This is a short summary of the covered services within the School-Based Access program as defined by Leader Services, and that was true for almost 20 years. And you can see that all of these things are typically billed to Medicaid by school districts and funded routinely through the School-Based Access program. You can't duplicate services. So if early intervention is funding behavioral health an hour a month, you can't come in and do behavioral health 35 hours a week. All you have to do is wake the parent up to say, your choice, ma'am, an hour a month or 35 hours a week. And it's a no-brainer. The parent's going to discard this because it's virtually useless in that domain. Early intervention may be terrifically helpful in other areas, but it falls woefully short in the behavioral health domain. So once parents understand that they aren't forced to choose between either or, they can have both. Once that dawns, now you have an entirely different ballgame. There is a loophole in Pennsylvania law. Did you ever hear of the loophole? Okay, this is one of the most awful things that the Department of Public Welfare has ever supported. The concept that there is a loophole in the law that allows families who have more than the federal poverty level of income to have their children who are disabled receive access to EPSDT funding. The state calls it a loophole in writing. It's not a loophole. It's in fact the state's law, like 36 other states, regarding access to EPSDT funding. It's available regardless of family income, period, because it's intended to prevent and treat and maintain functioning in disabled children. So we call it a loophole, right? But you got to understand the concept of medical necessity. Now, this is a quote from the Leader website, and I think it's still applicable to most people who implement school-based access programs. This is a quote. Think of medical necessity as being medical/educational necessity. What? This is starting to sound a little skitsy. Under IDEA, a child is entitled to a free, appropriate public education. Right, FAPE. But in order for a child to receive this education, he or she must receive medical and mental health related services. Okay, I get you there. But consequently, staff wear two hats, one medical and one educational. Are you kidding? That's called a dual role, and it is explicitly prohibited within the federal and state laws. You can't wear two hats. Recognizing the medical nature of the services provided is critical to proper service documentation and payment to the school-based access program provider. I don't know if that contributed to Leader's loss of their contract, but there's something funny about that. We all agree? Yes? Let's look at examples of Medicaid fraud as defined by the Bureau of Program Integrity. This is the organization within the Department of Public Welfare, the state Medicaid agency, that determines whether or not fraud has occurred. And one of the things they cite in writing as an example of Medicaid fraud is billing for duplicate services, and this could mean billing two different sources for the same service. Now, what happens when a school bills the taxpayers through the local school tax for the services by the speech therapist or the guidance counselor or the school psychologist, and also bills Medicaid for those same services? That's been going on for 20 years or more. It must be legal, right? Otherwise, the schools would be violating federal law and have tens or hundreds of millions, billions by now, of Medicaid dollars to pay back. I don't expect that to ever happen. But just understand that the Medicaid laws are very explicit in attempting to control fraud, waste, and abuse. So when you do Medicaid services in a school, you have to be damn sure that you're complying with the Medicaid laws, not just functioning competently in the education universe. The Office of the Inspector General conducts audits periodically. In April of 2010, New Jersey had to pay back $8 million. Wait, in March, Missouri paid $20 million, and in 2010, that was the last time I surveyed the literature, Arizona paid $21 million back for Medicaid claims in the schools. It's not a good idea for schools to putz around with mental health treatment, especially if it's being funded by medical assistants. I think that speaks for itself. But here's the history of the Medicaid education connection. You know, in '67 we created Medicaid. In '75 IDEA was created. Shortly thereafter, in 1989, when the mandate for EPSDT was created, there was a memorandum of understanding between the Department of Education and the Department of Public Welfare, which is the state Medicaid agency, and they then shortly thereafter created the SchoolBased Access program. And SchoolBased Access program allows mandatory movement of Medicaid funds into the education system to supplement the special education budget of the school, whatever that means. It all drops through into IDEIA, and shortly after that, schools started saying, we don't do mental health, and they started literally referring families to managed care companies to manage their responsibility under IDEA to provide related services, including behavioral support. Behavioral support is a related service. We all understand that. It's enumerated in IDEA, isn't it? No, it's not. Behavioral support is not an enumerated related service in IDEA. And that is the only thing that allows schools to say, go talk to the insurance company. A smart parent can get behavioral support services written into the IEP as a related service for their child, and that is absolutely essential. Some smart school districts will oppose that to the point of due process, and unless a parent can, put up the money demanded by some of these lawyer advocates, tens of thousands of dollars to fight it, they're not going to win. The school wins because in 2004 they amended IDEA to mandate that if the parent attempts to raise objections or other legal maneuvers during a due process hearing, that can only be done by an attorney. So it mandates that the parent has to hire a lawyer to exercise the rights that the federal government gave them in 1975. So we have a corrupt education system from the local level all the way up to the Department of Education. It's a tragedy, but it's a reality. So the trick is to convince the school that they don't have to pay for it. They do have to make it accessible if the child needs it, but they aren't obligated to pay for it. I'll show you how. Sometimes, unfortunately, schools get confused about the connection between themselves and Medicaid. And this diagram pretty much separates the two. Schools are obligated under child find, that is their charge. The Medicaid world is obligated under the EPSDT mandate to fund treatment. Behavior support plans exist in schools. Behavior treatment plans exist in the Medicaid world. It's effectively the medical world as opposed to the education world. Schools are obligated to implement the least restrictive setting. The Gaskin settlement and Olmstead and various other laws require a kid to be educated in the least restrictive setting necessary in which a free, appropriate public education can be delivered. And by the same token, the Medicaid mandate does include an expectation that treatment is rendered in the least restrictive environment necessary in which it can be delivered. Let me ask you a question. Which is more restrictive? Treatment in a doctor's office that you got to shuttle the kid across town and you can only meet 2, maybe 3 times a week. Okay, that's one form of treatment. Or treatment where a therapist comes to the home or the school and meets with the kid 3, 4, or more times a week, involves their siblings, their peers. Which is more restrictive? Having to trundle the kid to the doctor's office or having the kid see a therapist? For God's sake, nobody in their right mind would call the doctor's office a less restrictive intervention except insurance companies. Kids from birth to 21 are entitled to funding throughout the Medicaid process. Medicaid follows HIPAA, the education system follows FERPA, and you'll notice that the only conduit between those two systems has to be the parent, because the parent has access to school records, not the medical side, and the medical side, through the parent, can give information to the school or withhold it. Why does the school need to have the medical diagnosis and the medication history of the child? Why do they need that? For education planning? I don't think so. For classification as to which school, classroom the kid belongs in? I don't think so. Schools don't diagnose, they classify. Medical doctors diagnose for the purpose of monitoring treatment and obtaining funding for medical care. If the parents want to share stuff, good for them. They should, if they think it's in their child's best interest. If they know otherwise, they can legitimately withhold information from either side. What right does a medical agency have to the kid's IEP? They have no such right. They're not entitled to it. And all you have to do is tell the parent what their rights are under the law, like you're supposed to do, and that crap stops. And the insurance companies cannot use the kid's IEP against them. Well, he's got a teacher's aide in the classroom and there are only 7 kids in that class. We're not going to fund EPSDT treatment under this basis. You know what? The Department of Public Welfare 3 times so far has said that that's not permissible. They're not allowed to. Insurance companies are not allowed to influence their decision regarding the medical necessity of a child's treatment based on their opinion of the kid's education program. In writing 3 times. Has anybody heard that they're still doing it? Shout out. Come on. How many of you? Lots of you. So why is that happening? That's a rhetorical question. We know why it's happening. Because you guys didn't know that it was illegal. Well, maybe now it'll stop, right? You have to have courage because you have to point these things out. And I will be happy to send you the resources that you need to make it clear in a language these people will understand. It's bad when a school tries to be the bridge between Medicaid and FAPE. It's a bad idea. It exposes the school to liability that they ought not have. So what I recommend instead is that they don't raise the red flag and they keep those 2 things separated. The parent's the conduit between the school and the medical agency, and FERPA and HIPAA are not compromised. And you don't fall into the role as a school of being a jack of all trades. What are you the master of if you're now the mental health provider too? What else can you do? You're going to be inefficient at it. You'll be deficient almost by definition. So here's the way I'd like to have it set up. Education takes care of education, following FERPA, delivers FAPE. Mental health takes care of mental health, follows HIPAA, delivers BHRS that meets the student's needs and enables the delivery of FAPE in the least restrictive environment possible. This is the way I've been doing it for almost 20 years. So I have some basic recommendations. First of all, the services have to be closely supervised by licensed mental health professionals. You implement programs that are clearly written, that identify specific measurable goals and outcomes that are school aware, and incorporate evidence-based practices, including the wraparound model. I'm a big fan of wraparound. I used to be a member of the National Wraparound Initiative until I got tired of them not vigorously refuting the fact that wraparound is a substitute for treatment. Wraparound is a nice way of managing treatment, but far too many people think that it is a substitute for treatment itself. We'll go into that shortly. Outcome data has to be taken from the recipients of service, not the providers. If I ask my staff, hey, how'd you do last week? I did great. How'd you do last week? Keep going. You're going to get this relentlessly, and it's all human nature, and it's all irrelevant. I want to ask the parent, Mrs. Jones, on a scale of 1 to 10, how frequently has your child displayed this target behavior? And we identify it. And they say, well, you just asked me last week. Well, I know, but since last week, how frequently has it been happening? Oh, I don't know. What did I say last week? Well, last week you said a 4. Well, it's about maybe a 5 now. It is getting worse. Okay, Mrs. Jones, you are now contributing to your child's treatment on a weekly basis. And you're feeding back to us how your kid's doing in an objective way. That's called a single subject with repeated measures experimental design. It's a way of documenting treatment that works. I've been collecting that data for 10 years. We've treated over 1,000 cases and have records for the entirety of their treatment progress. And when those records were reviewed by the University of North Carolina, by Thomas Jefferson University, by Villanova University, and by Immaculata University, independent researchers at all 4 of those institutions looked at the data and said, whoa, now we can't say your treatment caused this, but heck, there's over 1,000 cases here, and 75 to 85% of them got better. Whoa, this is remarkable. This is a statistically significant result. The probability of it being attributable to chance is less than 1 in 10,000. It's a colossal success. You should have this published in every journal on earth. Not one of them accepted it. Why? Well, they say we didn't have a control group. Okay, so you've never heard of a study reporting results of anecdotal reports of progress? Of course you have. Those studies are published all the time. This study relates to behavioral health rehabilitation services, and it is being actively suppressed by all kinds of people who you never thought would stoop to a level that low. And they're doing it, and they're doing it for a living. So the bottom line is we have the database that shows that BHRS works, that it's effective, and 92% of the population at least is finished within 3 years. And if you take data that shows that the kid's making improvement in the course of treatment, now you've got a solid system that will resist fraud, waste, and abuse. If you do the system I just described, you're going to be able to help lots and lots of people. You will keep the unscrupulous bastards out of the system or excuse them appropriately. And that needs to happen. There has to be some legit oversight of the wraparound system, if you want to call it that. I want to go through a quick rendition of the way we do things at the Institute for Behavior Change, and I call it putting BHRS in a wraparound cup. This is the logo we created, and you'll notice a wraparound cup is a prominent part of this. And I want you to understand that wraparound without effective treatment inside it is an empty cup. You can wear it for a hat for all the good it's going to do. You have to have legitimate treatment inside it in order for it to be effective. Eric Bruns, who's one of the co-creators of the Wraparound Initiative, said, and this is his testimony in the JKV Eden lawsuit, this is federal court. The term child and family team process is used to refer to the process of planning and delivering services through a child and family team. This is the process to which I refer when I use the term wraparound process. So Eric is very clear here saying that wraparound is not treatment. And you can look at this slide and you see that care management, which he also refers to in the wraparound process, is not treatment. Intensive case management is not treatment. And ensuring that interventions are leading to improved outcomes is not treatment. Those are all legitimate things, and I believe in all of them. Those are worthwhile goals to pursue, but they don't constitute treatment. This is a segment from the National Wraparound Initiative's Wraparound Fidelity Index. Using this instrument, any organization can identify the extent to which it is implementing wraparound principles. And when we did this with the Institute, we scored very, very highly in the Wraparound Initiative's index. The only area where we scored low is that in the wraparound world, they have what I think is a misguided understanding of the role of the professionals. Unless I and my staff know more than the parent or the teacher about how to treat behavioral mental illness symptoms, we have no business being there. We have to have a higher level of expertise than they do. That doesn't mean we trump them and they have to listen and obey. In fact, they have to agree with us, or it's no go. But it's not a case where we're on the same level. They actually have more authority than we do, but they don't have the authority to command to us what we must do to satisfy them. The Wraparound Fidelity Index is used to measure fidelity to the wraparound process, not to measure the effectiveness of treatment, because it doesn't measure treatment. Wraparound and treatment are two different things. Something else to realize. Russell Barkley, who is the world's leading authority on ADHD, has put it in writing, and I'll quote, "The treatment of ADHD requires a comprehensive behavioral, psychological, educational, and sometimes medical evaluation, followed by education of the individual or their family members as to the nature of the disorder and the methods proven to assist with its management." Do you hear him saying that medicine is the treatment of choice in the treatment of ADHD? Of course not. He knows that the study purported to come to that conclusion was flawed. It was a New York Times front page headline a few years ago that the doctors admitted that they cooked the books, that medicine is not the treatment of choice to the exclusion of everything else for ADHD symptoms like most psychiatrists believe it to be. This is a summary of the way we approach treatment, what we do. You'll see it in the purple brochure back there. Please take that with you so you can see how BHRS can be implemented under the EPSDT mandate. All it literally takes is a licensed prescriber of the healing arts, and that can be a psychiatrist or a psychologist or any other physician in this state. They prescribe exactly what I would prescribe. If you go to treatmentplans.thatworked.com on the internet, you can get 576 treatment plans that worked with the data that supports the fact that they worked. And those treatment plans can be used as a foundation for creating other treatment plans for similarly situated children. Girls, boys, kids with autism, ADHD, they're all there, dozens of them. So you have a licensed practitioner who prescribes a treatment plan exactly the way I would have, based on treatment plans that worked or some other consultation with me. And they give that prescription to a parent. The parent takes that prescription to the state Medicaid agency and says, I want you to fund this. This is exactly what was prescribed and funded by EPSDT in Pennsylvania, or Chester, or Delaware, or Montgomery, or Philadelphia counties in Pennsylvania. And I insist that my child gets this treatment funded under EPSDT just like these 16 other kids did. And if the state Medicaid agency in Idaho or Iowa or any other place in the nation says, no, we don't do that here. Here's your breath mints, go home, right? If they do that, they have violated the child's civil rights, just like that. And now the parent can make a contact to the Office for Civil Rights online without need for a lawyer whatsoever and say, hey, this is what just happened to me. Can you please investigate this? And guess what? The Office for Civil Rights has to investigate it, will make the phone calls, and ultimately the state Medicaid agency, I believe, is going to get a phone call, and somebody in the governor's office or somebody's going to say, hey, look, call that parent back. They're right. We don't need this aggravation. And that's when you're going to get the, okay, look, you're just don't tell anybody conversation. I think. At least that's one possible outcome. The other way it could work is they could say, you know, you're right. You're absolutely right, and your child's entitled to this, and it obviously meets the standards for the state's definition of medical necessity, so we're going to fund this. The only problem is, in other states, the definition of medically necessary treatment is not as broad as it is in Pennsylvania. So that's a potential problem. But in every single case where the exclusion of treatment because it's experimental or the exclusion of treatment because it's too costly have been struck down in federal court 100% of the time. So if there's an enterprising attorney out there somewhere who wants to make a name for themselves, this is the ticket. In the course of our evaluations, we do an ongoing assessment of whether or not the child needs BHRS still. It's a continuation checklist. It's based on the work in the Pennsylvania and the American Psychological Association about how to determine if treatment should be continued. Basically, the family and you, as a treatment provider, have to be on the same page. You have to agree the treatment is still necessary and that it's working. If those things don't exist, then you don't have a rationale for BHRS. There's one circumstance under which BHRS is not permissible, and that is when the child cannot be maintained safely in the home and community. When you've got a kid who is eloping in the middle of the night, he's 9 years old, the cops bring him back to the parents' house by the grace of God. It wasn't the grace of God, but close to it. He got on a bus when nobody was looking. He got on the back door, climbed up and hung out, rode the bus. This kid has autism. Rode the bus to another town like 8 miles away. When the bus driver saw a kid in his underwear getting off his bus, he said, "Stop the presses, something's wrong." Called the cops, and fortunately, that child's photograph was listed with the local police departments and circulated. Thank God. My staff told the parent to do that a year ago, just in case. This is another example of how my staff literally are saving lives. One of the things you have to assess in the treatment of any child is the extent to which they've been exposed to trauma. A lot of kids are exposed to trauma. So what does trauma do? Kid's got ADHD, but he saw his father murdered by his mother. You know, it's some horrific thing. What does that do to the treatment period? Right? So what does an insurance company do when they ask you to collect trauma data and then ignores it? Because the treatment's supposed to be finished in 3 months. This was supposed to be a time-limited service. We do sensitivity training where we help the staff understand that there are a variety of things that parents can do, schools can do, anyone can do in the treatment of a child to promote privacy and dignity. When you have privacy, you have a sense of self-security, safety, and you're free from embarrassment. When you don't have privacy, you are at risk for developing paranoia, defensiveness, behaving in an aggressive and withdrawn manner, and likewise, when you have dignity, you have self-esteem, satisfaction, a hopeful and optimistic outlook, and you tend to have cooperative behavior. So if you see uncooperative behavior, you've got to look at to what extent has the person's dignity been violated. Fix that, and maybe half the battle's over. In every kid's life, we have performance and reinforcement grids. Performance grids identify those times in the day, week, whatever, when the kid has a particularly stressful level of performance expectation. In the reinforcement grid, what do we always do? They get their treat at the end of the day, or some idiotic thing like that. What should happen is this. Reinforcement should be given to the child on or shortly after the period of highest stress. They do the job, they succeed, they get something for it right then and there. They don't have to wait until the end of the day. Doing just that will do more to change child behavior than any other intervention. We also encourage the staff to use the model of climbing the staircase. What happens to the volume on the left side of the screen as you climb the staircase, and what happens to the volume on the right? The volumes stay the same overall, but the caretaker's part gets bigger as you climb the staircase, and the provider's part diminishes. How do you accomplish that? I'm going to show you. Over the course of appropriate, successful treatment, this is what it looks like. Before you start, that's the squiggle to the left of the graph, that's called a baseline. Things are pretty bad. You start treatment, and the kid says in a variety of ways, "You and what effing army?" Right? That's called an extinction burst. But the trick is, you lay this out for the parents before you start and say, "Look, Mom, you're in for it, but it's going to be a new dawn once we get them over that hump." And it's a hump. It's not a crisis. So what happens if 3 weeks out, it's still up bouncing off the ceiling? Oops, you done miscalculated. You got to do something else because it's not working. All right? So if it works, it's going to go down. You may see a little shadow of the hump later on. That's called spontaneous recovery. And even later on, you may see an echo of it at the end, and I don't know what that's called. It's not really in the literature, because everybody stops talking about it after the first bump. But we've seen that echo periodically, and we know it happens. So we tell the parents, when you see the bump, that's not the time to quit. That's not the time to call it a failure. When it turns into a plateau, now we got a problem. And if we take data every bloody week, we're going to see it, even before the parent does. And that's the goal of a professional treatment program. This is a sample of our treatment plan. You'll see it in the handout. This is a blow-up of the methods that we use, typically for a particular child. You'll see that we talk a lot about TSS, Therapeutic Staff Support. That is the person with a bachelor's level of training who goes to the school, goes to the home, works with the child, and gradually over time gets farther and farther away until they're not needed anymore. And that's legitimate titration. We also titrate by the intensity of the prompting that you give the kid. Instead of saying, no, do it this way, that's physical prompting, we say, no, do it this, remember like I showed you, that's verbal prompting, and then there's gestural prompting, like you need a timeout, pal, let's go for a walk. And then there's checklists. It's a visual schedule. So we're doing less and less to interfere in the child's life on an ongoing basis. But let's say on Tuesday we're over here, we're at the back of the classroom and things are looking good. and the kid has a crisis. The little snot-nosed brat next to him punches him, right, for no reason. It happens. They're children. So what does our staff do? Stands in the back and observes it as the ship is going down? We immediately zoom in and we help the kids settle down. There's no loss in the fidelity of the child's treatment program. Now, could we do that if we complied with the insurance company insistence? You know, they put on their Nostradamus hat and they say, we think that in 2 months the child will need 50% fewer services. On the basis of what? The data shows it's going to get worse. And you're saying that you can predict that it's going to get better. Wow! The third page of our treatment plan is bean counting. There is a place for recording the number of incidents of physical aggression that occur in a kid's day, but also in the lower part, a means of recording the replacement behavior that's occurring. And both of those things, the target and the replacement behavior, are explicitly listed on the data collection sheet. And then here we have antecedents and what the caregiver did in response to the treatment that was provided. In other words, there's an awful lot of data collection that goes into the maintenance of these behavioral health rehabilitation services. This is not a superficial intervention, and we don't treat kids who are the walking wounded. We treat kids, if you're familiar with the tier, the top 1 to 10%, we treat the top 15 to 20%. Because you don't have to be in Tier 1 to get BHRS. And in fact, if you've got a kid who's doing really well, but who needs the support of the treatment provider, it is technically possible to have that treatment provider in the classroom at a distance from the kid, enabling the child to get that support until he turns 21. The way we cope with that, because sometimes parents say, he's entitled to it, and you have to give it to him. Okay, sometimes parents get that intense about this, and we have to cope with that too, because that's not appropriate. That's the tail wagging the dog again. So what we do is we put the TSS outside the room, making visual contact with the child. They're not even in the room. And they do that for 2 weeks, and they document, he's finished. And it's an unassailable proof to the parents, to the state, that we have concluded a treatment program correctly, ethically, successfully. This is the page of the progress note form where the staff can literally circle the interventions that they used. I don't really like this so much that they just circle. If they circle the same thing every single week, what are you dealing with here? You know, it just makes me, like the smoke curls out of my ears when I see that. So we have master's level mental health professionals reviewing these things every week. And those people supervise the TSS. And when the master's level mental health professionals see the same damn thing every week, they talk to Eddie and say, son, come on, you can't do this. We can't keep you as an employee if you keep this up. What happens if they're found sleeping one time? They got a new employer, period. No questions asked. You can't excuse that. But some places do. And what happens if you complain to the state Medicaid agency or the Bureau of Program Integrity that, you know, Ed, the TSS for that company, was sleeping for the last week straight? What happens when you report that? Who's the first person that they investigate? You! They check you out to make sure you're not making a bad faith report. There's all kinds of ways to suppress good and truthful treatment. It goes without saying, but you got to do it anyway. You've got to advocate for it vigorously. The final page of the treatment plan that we create includes 4 mini plans. The first is a discharge plan. So we're planning what are the criteria to remove the child from treatment because they've finished. That's the bottom one. The titration plan allows the TSS service to be reduced by distance and by hierarchy of prompting, not by quantity. So what we do is we have 20 hours a week, 20 hours a week, 20 hours a week, 20 hours a week, and when we finish the treatment program, we can definitively say he doesn't need this anymore. It's unequivocal, satisfies everybody, including the child whose needs are being met, without exception. Then we have a transition plan where we want to transition to low-cost or no-cost services on an ongoing basis. You want to get the kid involved in a church of some sort. I'm not a practitioner of evangelism here, but one of the best resources on earth for a family with a disabled child could be a church. And I think we should advocate for the integration of children into their community and not neglect or overlook the church as a primary place to start. The local Elks Club or the various other service organizations can often be helpful. YMCAs, YWCAs will give scholarships. There's all kinds of creative things that can be done to supplement the good work of the behavioral health rehabilitation services provider, and it's all funded under Medicaid, as long as you write it in behavioral terms, focusing on the amelioration, prevention, or maintenance of functioning under the EPSDT mandate. And the top one is a crisis plan. You have to know what to do in the event that there is a crisis. You climb a staircase, there are no landings on it. If things escalate, you have to know what the steps are, up to and including perhaps a contact to the police to have an intervention in the child's life so that their dangerous behavior can be stopped. We also have guidelines for providing school services, BHRS, in the schools, written statements that reassure the schools, hey, look, we know you guys know you're obligated to provide related services, right, including behavioral support to the child. We know you know that you have to do that to give the kid FAPE, but this is a statement that says, okay, you're going to allow my outfit to come in and do that. So you're going to allow it, the kid gets FAPE, and Medicaid funds it. It's a win-win. The BSC, the tiny little dot in the center of this spider web, is one of my master's level mental health professionals, and they are literally contacting with all of the people around there, including the school, the other members of the BHRS team, the parents, the grandparents, sometimes siblings, the whole web of people who could influence the kid's life. They can all make those contacts, and under the scope of practice of a licensed psychologist, a BSC can make those contacts in the context of the child's behavioral health treatment. That's not case management in a psychology practice. It might be case management in a community mental health center or something like that, but in a psychology practice, we don't have case managers. The behavior specialists are legally allowed to do that, and it's necessary for them to have those contacts. We follow the CASP principles, Child and Adolescent Service System program. That's a necessity. It's part of the state Medicaid plan, that we have to use strengths-based interventions, use a child-centered and family-focused approach to treatment, etc. We record behavioral data once a week. Not only do we ask Mrs. Jones, on a scale from 1 to 10, how frequently has your child displayed the target behavior that we operationally define, but also, how severe has it been? Yes, he was in a fight. He hit somebody. But today, he broke his nose and, the kid had to go to the hospital. That's a 10. But if he punched him, you meanie, that's a 1 or a 2. So we differentiate between those two things, and then we graph them on a behavior record graph that shows the kid's progress over time on a week-to-week basis. This is one of the graphs that we submitted for publication that got rejected. You can see on the left-hand side before TSS, on the right-hand side after TSS. That is a statistically significant change. Here's a more dramatic change. So we collect this data with 1,000 cases. We have 850 that look pretty much like this. Of course, we can't claim that we cured anybody or that we did anything significant. It may have all been attributable to chance. 1 in 10,000 chance. Okay, but we have to tell that. Here's another example. We separate those three things out, and in this one you can see that the blue line went way down, the green line went way down, and the pink line went down, but not quite as dramatically. This is a summary in the white brochure of the University of North Carolina and the Thomas Jefferson studies. The one on the left was for 4 months, the one on the right was for 1 year. The conclusion is that the kids continued to get better over the course of that year, and actually the ones who stayed in treatment for a year almost universally got much better than the ones who dropped out prior to the year. Our ongoing treatment research shows that significant reductions in outcome measures occur for physical aggression, lack of environmental safety, non-compliance with adults, communication deficits, and socialization deficits. These changes happen regardless of gender, regardless of diagnosis, and the best part is there was no halo effect. In other words, when the staff stopped doing treatment, the kid didn't plummet, right? And when they started treatment, it didn't skyrocket back up to excellent. The changes occurred gradually and simulated a natural learning curve. As the kid got less and less reinforcement, the troublesome behavior crept back up over 3 to 4 weeks. As the kid was immersed in treatment, they didn't suddenly get better. I mean, sometimes you get a halo, but most of the time you get what? An extinction burst. When you start telling the kid things are different now, they say, you what in what effing army? And so all of the data we've collected without exception shows that BHRS is a viable treatment modality when it's implemented conscientiously by professional providers. The bottom line to take home is you can't drive a tack with a toothpick. And if an insurance company or a school or somebody else says, yeah, he only needs a toothpick, of course you can reject that out of hand. It's crazy. But if you apply it to behavioral health treatment, wait for it, the National Academy of Sciences in 2001 and the American Academy of Pediatrics twice in 2007 and 2012 all said that a child with autism spectrum disorder symptoms, and that includes ADHD for the most part, a child with that symptom picture needs a minimum of 25 hours of intensive individual treatment every week, including the summer, to have a reasonable probability of symptom abatement. So we have the National Academy of Sciences and the American Academy of Pediatrics twice weighing in over here, and we've got your local insurance company weighing in over here. These guys say 25 and up. These guys say 5 and below. Who is telling the truth? That's a rhetorical question. Does anybody think this hand is telling the truth? Anybody? All right, we have about 2 minutes left. I want to leave it on that note. You have national authorities that are supporting you. You have the federal government through the Department of Justice and the Office for Civil Rights that are supporting you if you're a disabled child in need of treatment. What do you need? You need a licensed practitioner who is courageous and will prescribe treatment for the child in accordance with what I'm doing now for the last 20 years. It works, it's effective, it's cost-free, and it can be in your neighborhood if a licensed practitioner just prescribes it. I can help them get the prescription right, I can help the family submit it to the right authority, and I can help support them when they get denied, thwarted, or misdirected by any of a variety of sources. Thank you for coming. I appreciate it. It's gratifying to see such a large group coming out to hear me talk about this.